Good morning, everyone. And I want to welcome you to our first Grand Rounds after Labor Day. We're starting in earnest our academic year. And I know that for the junior residents and the intern, it starts a little bit earlier in the middle of the heat. But for the rest of us, this is a great start for our Grand Round program. And it gives me great pleasure today to introduce to you one of our faculty members that I think you will gain a lot from listening to her, talking to her, and working with her. This is Dr. Amy Waterman. Dr. Waterman is the Deborah C. and Clifton B. Phillips Centennial Chair for Clinical Research in Transplantation Medicine at the department and the J.C. Walter Jr. Transplant Center. Dr. Waterman is a professor of outcomes research and surgery in the Academic Institute. She's the director of patient engagement, diversity, education in the Department of Surgery and the Center of Health, Data Sciences, and Analytics at Houston Methodist. Really big titles, but they truly fit into her amazing portfolio of work. Dr. Waterman got her doctorate degree from Washington University in St. Louis. And before she came to us, she was faculty member at UCLA School of Medicine and Washington University School of Medicine in St. Louis. In these two places, she's built a very impressive portfolio of work, really centered around patient engagement, access to care, and diversity and inclusion. And her work in transplantation in particular has been nationally and internationally recognized. He created an organization that really, it's called Explore Transplant, that has helped introduce the concept of living donation to thousands of families and people across the states. She became an opinion leader in that. She won almost $30 million in grant funding. She, I have a list here of about a page and a half of things that she's accomplished, but suffice it to say, she is basically got crowned in the last couple of years by the American Society of Transplantation when she won the award of the greatest contributions to clinical transplantation by a non-physician. That's not a small task or a small feat, but Dr. Waterman was able to do it. She is now one of our faculty members. And I think we have some of our residents. Andrea is working with her, and I hope more of you will find your way to her lab. Whether you want to do research or just want to learn about diversity, engagement, and so forth into patients, she is a great mentor and a great teacher. And today, she's going to talk to us about AI in medicine, which is a very interesting topic. Amy?
Thank you, everybody. And so wait, there's a new class here that's starting, plus the established people in this room? Okay, new interns, raise your hand. Welcome, this is week 1? This is what, week 100? Week 3. Okay, I want to say on behalf of all the patients, I stand for the patient engagement space of this. We're so happy to have you here and for the difference that you're going to make. And everyone else that I have had the chance to see around and work with, I adore you all. So I am so happy to be here and to be asked to speak for Grand Rounds. And a lot of times I speak about something that I've been studying for sometimes up to 20 years. And so what I thought we could do today is we could talk about this animal that has entered the healthcare space called AI and machine learning and see how it might apply to health. And I want you to feel free to kind of comment on things too, because I'm discovering just along with you. I also want to introduce you to these amazing people. So when I came from UCLA, they said, would you be willing to be the director of patient engagement, diversity, and education? And I said, only if I can have an incredibly diverse group of leaders to partner with me. So I wanted to show you these amazing faces, to thank them for all their hard work with me, and also to really get diversities, not just kind of the culture, race, ethnicity, things like that. It's also all the training. So between Andrea, who's in the room today, we have people that work in health services research, education, patient. I don't know, the way that one of the big messages I want to say right from the beginning is this isn't a doctor-only world, right? I'm a psychologist, social psychologist, trained in behavioral change. I've had the incredible honor of working with surgeons my whole career. I adore you. And together we can do more. So today I want to talk about artificial intelligence and machine learning and what we're discovering, literally on the cusp here, about how we can apply it to healthcare, but also the possible biases that might show up. I want to talk about the health disparities space that we're trying to make a difference in, and how do we put these two together so that we can increase access to transplant. So what's artificial intelligence and machine learning? All of a sudden, I don't know about you guys, but it felt like everyone's talking about it in every single dimension. Is that how you guys felt? Like we weren't talking about it? Before this, it was the Terminator movie. Remember the Terminator movie? So basically, artificial intelligence was a robot, and it tried to murder you if its algorithm saw that you were a bad person, or a person, period, right? Then ChatGPT exploded. And now you could write your papers with ChatGPT faster than if you wrote them, right? I want to let you know, just a piece of ChatGPT data, that in the research space, you don't put ChatGPT as an author on any papers that you're involved, although you can use it. You have to disclose that you've used it, and you also have to explain where. So, and ChatGPT records the part that's written. So I've been in the research space talking about ChatGPT. It's very fascinating. But those are the big, loud conversations. I want to bring it into what we do every single day. And I want to say, okay, well, what is AI? What is machine learning? And how can this make our jobs easier and a better experience for our patients? And so this cartoon, I think, is kind of funny. So basically, machine learning is a subfield of artificial intelligence that trains algorithms using a computer and also builds learning models that can perform complex tasks, okay? And so they say, is it better than us? Is it worse than us? Is it better than us? Is it worse than us? Okay, these are kinds of areas in which AI and machine learning are starting to be applied in the space of health. I think this could be quite exciting. So in the diagnosis, treatment, and management space, we could be looking at medical images and using computers to scan them to detect health problems. We can be working in precision medicine, really looking at an individual person and their risk of things and what exact protocol health-wise might help them. Surgical robotics, there's experts here that are surgical robotics experts, and drug development, all dealing with preciseness at a level that we haven't gotten to yet. In my space, patient engagement and support, we're looking at all of those points of patient care that are repetitive, and often there could be a gap for a patient. So they called one time, they didn't get a call back. Now if we have a telemedicine system to set up appointments, to respond to them by text, all those things kind of can get covered. The other part is this interconnection with health IT. We have a lot of data that's coming in where we can not only have data that we're collecting here in the hospital or at a lab, we can also have data streaming now from various wearables that, you know, we know with Fitbit and those kind of things, but it's getting all these levels of preciseness. You deal with all of the language and the cultural assistance needs that we have. You can now have technology be doing that instead of waiting for a interpreter. And then conversational AI, where the AI machine is talking to you. For example, what's happening in the Center of Innovation is that they have the speaker where the patient can say, I need someone to come in, I need a blanket. They have all of the requests now that those things can be sent in to speakers in the room, and we can then be more responsive and have those things be automated. The intention is this could be better. So then we move to natural language processing. This is something where the computers can scan epic records. They can look for gaps in, this patient possibly needs support getting home from the hospital. They do not have access to a car. Okay, those kind of things can be scanned versus having for all of us to read. In the space we're going to talk about today, there can be a lot about data extraction that's happening and data analysis, and then even these making appointments and billing can be automated. So what is happening now is an explosion of companies, startups, tests of efficacy. And what I want to say as a person who lives in the space of this is that how do you put this all together? And Dr. Gaber and I have talked a lot about this. And so if you think about an optimal care delivery pathway, the first question that you should ask yourself, because you're all looking at this from your lens, and I respect you can see things I can't. So the thought would be, okay, I do what I do. Where could we apply AI or health IT solutions to improve or deepen the patient experience and make it easier for us It's not that making it easier isn't crucial. It obviously is with all of the number of patients and the touch points that we have. But how could the patient see this as a contribution? But then you go, okay, there's AI ideas on that. Okay, then you think, okay, where can we not do that? Where is the compassion and care from a clinician or educator essential? And if we put an AI solution, we would lose part of the patient experience, right? So you can kind of get, like, there's an efficiency and an ease, and then there's a point of separation, and they don't feel taken care of. So how do we balance both of these at the same time? And so the key place here that I think the field should be looking is how can we build care delivery improvements that can incorporate the best of both? And what is the best of both, and how do we know? So talking chronic kidney disease, I know most of you know this, but the key thing is I'm working with Dr. Shafi and Dr. Gaber, where we're looking at patients along the entire spectrum of chronic kidney disease that are here. So I don't know if you know this, there's about 4,000 patients every year that are referred to nephrology. I didn't know that until preparing for this talk. And so then a certain significant part of those people who are in the red areas of their kidney function, they're in stages 4 and 5, start meeting with the transplant center. And we hopefully can get them a transplant if that's going on. The problem is this isn't a consistent group of people moving through the pipeline from chronic kidney disease management, trying to avoid their kidneys from failing, to then being referred here. There's all sorts of gaps in the care delivery pathway. And there's lots of reasons why, and it's most likely to affect Black and Hispanic patients, particularly where we have a lot of cardiometabolic disease, and then they're more likely to have kidney failure, 4 times. Black patients 4 times increased with risk, Hispanic patients 1.3 times increased risk, and all of these patients are not necessarily even coming to us. The other part to show you kind of a movement of how what data is showing is we want to get patients to transplant. People like me, people like you are all saying transplant is a good option. Maybe we should get people here. And what we have seen over time, if you look at 1995 to 2013, is we're actually having an increase in white patients getting a transplant and a significant decrease in Hispanic, Black, and Asian patients getting a transplant. So it's getting worse. So basically, we have inconsistencies in caring for patients, and then we have patients that are Hispanic and Black not as likely to get a transplant. So why? Okay? Now, I know you know this. I know this. People know this. But let's put it together. So the first part is there's been a lot of push in the literature, in NIDDK, in grants, to say, but if they get to us, it's too late. The people who you all have the chance to meet in transplant are the best. They've maneuvered through all the complexity. They're here for a great place. They have health insurance, all of that. If we go, they say go upstream, okay? The people here, we're doing great. We need to treat them well, but we also need to look at who we lost. And so what we're really saying, and I'll give you an example. So they talk about structural racism, which is about that the system, it's nothing about the person, but the system is set up so that the patients within it will fail. So here's an example. We tried to write a grant when I first arrived here, partnering with Legacy. Does anybody do care at Legacy at all? This is we have a partnership where we send doctors out, and this is a place where they do primary care for people who are underinsured, okay? And the idea was we're going to improve the CKD care. We're going to bring more of us. So I got all of these people, Houston Methodist. We're going to send more doctors. We're going to bring kidney care there. We're going to detect if they have what their creatinine function is, if there's a progression, a loss of creatinine function. We're going to give them blood pressure monitors. We're going to do all these things. It's going to be great, very heartfelt, a lot of people donating time, donating devices. So we went to Legacy and we learned 2 things. The first thing is, prior to this opportunity, we were sending people there, but they have multiple institutions of Legacy at different parts of Houston. We were only going to one day a week. So imagine how much kidney care would there be in an underserved population that are predominantly Black and Hispanic. We have one very good doctor, amazing doctor, going to do kidney care 1 day a week. So we're losing a lot of care, right? The second part is their medical record at Legacy was writing over their creatinine values from the previous time. So we did not know who had CKD, and we did not know their history over time, if they were declining, so that we could serve them. That's a structural racism problem. Does that make sense? They don't have a doctor, they don't have a creatinine assessment, they haven't been diagnosed with kidney, and they don't have the ability to get what they need there, okay? There are many, many upstream interventions that need to be built such that we can help the patients in our whole continuum. But then I know that once you know you have CKD, then the thought is, okay, are you getting it managed? Do you have a car? Can you come here? How far is here? I basically concluded that avoiding the Texas Medical Center is most people would prefer to do that, including me, right? In terms of parking and challenges and all of this stuff. So we're sitting here and the complexity Hispanics in LA where I came from, they were like, we can't come for medical appointments. Many of our community members are working 2 to 3 jobs. There are no off times. Do you have any CKD appointments in evenings or on Saturdays? We don't. Okay, so you can kind of see how this can get built. And then obviously all of the health insurance issues that are going on, and all of this is a part of kidney disease too. And so this leads, and I'll just read across the top, to patients having fear and insufficient knowledge about CKD and transplant, facing challenges that stop them from moving forward. Their families don't know what's going on. They don't know about needing a transplant. They don't know that they could be a donor. We have language challenges. We have healthcare system challenges and EMR monitoring challenges. So there are many, many people, clinicians and researchers, who are trying to overcome these and have been for 20 years. But the thing I want to remind you of, it's not working, right? So we need to think differently to say this will, my mom always says, well, you know, can you do the same thing and expect a different result? We got to look for where the innovations might be. So I want to show you a really interesting study about that this was starting to change my thinking. So I was at UCLA and we built a kidney transplant derailers index. And the idea was, can we tell who's going to derail ahead of time? Okay? Because then we could do something different. So we built a derailers index that had nothing clinically about their CKD care. It asked things like, do you have a washer and dryer? And how insecure is your financial situation? How long could you live in your home if you ran out of money? And what is your quality of your social support? And I want to show you guys this because this is fascinating. So these are just people with no data on who they are clinically. And you can see that the people who were scoring high on these kind of variables, that they were in a more precarious socioeconomic situation, they were, the red line is the people who have the most, the greatest challenges for both of these. So you can see if you look at the line on days to wait list, that they are spending longer to be waitlisted, and if you go up on the left, their waitlist probability is also lower. Same story with living donor transplant, where it's almost 0. So this is the point where the socioeconomic challenges are ending the possibility of transplant, right? So again, how do we do this? All right, so let me shift. So this was a good study. Always, there's no one perfect study. It's about a program of research. So this is like, okay, what's going on with this? How are we building indices to figure this out? So I want to shift to the NIH agrees with me. I think it's the reverse. I think I did something and the NIH was smarter than I was. But the thing that they built a large $50 million consortium. And they said, we want to create something called Artificial Intelligence Machine Learning Consortium to advance health equity and research and diversity. And they said, we want to use AI and machine learning. We want to look at large data sets, and we want to figure out how to address health disparities and measure these things and try to intervene. And we want to reduce bias in AI. So I was able to get one of their pilot grants, and I've been running this with a team that has been amazing with me learning as we go. And the key is, could we use AI and machine learning with the data here at Houston Methodist, not the UCLA data, but like, can we look at EPIC data and predict who's going to drop out ahead of time? So I also want to tell you something else that I have really enjoyed about this group. So I'm a patient engagement expert. I know transplant really, really well. I don't know AI and machine learning really, really well. So the idea was we bring all these people who have these expertise together, and it's sort of like speaking in different languages all the time is what I would say the meeting goes, because you get the AI people, then you get the analyst, and then you get the transplant people, and then they disagree. So I joke I'm in the middle as a mediator, right? And at the end of that, we can figure this out. But what I also want to say is all of these other places are having pilot studies as well, and we're combining data, which is very exciting. So let me show you how this goes. So if we want to build a data set that we can understand what's going on in a level of both the disparities and the socioeconomic issues and data that's not in EPIC and combine it with EPIC, how do we do that? So we went to the literature, as you should do. I highly recommend this. And we looked to see if there are kidney transplant registries that exist right now. So it's really interesting because we found a ton of them. But the fascinating thing, this is like an example of why, you know, you do the right thing and it's a good thing. The biggest one, the 3 million size UCLA Cure CKD registry, does not include transplant. They're looking upstream at kidney variables. So the details about when somebody appears and drops out of transplant, all that information they don't have in this registry. So then the question is, okay, well, who does? And we actually found a couple. So we're officially, with this little bitty pilot, which I want to make a lot bigger, are the 4th largest registry about transplant in the country. So we were celebratory about that, and people were really excited that we were starting to do this, and multiple CKD Cure wants us to partner with them. I want to do just a moment of thanks, particularly to David Hsu, because he has been doing the machine learning work here, but all of these people we've been working with the University of Houston, University of Iowa, Harvard, to really figure out how to do this. And our aims were simple. What are the variables that are potentially affecting disparities? Can we develop risk indices to predict risk of dropout at different steps? And what type of clinical interventions might help? So this was a year-long study only, with the idea that we could keep going. So I've shared this before, but I think this is such a great orienting image. So this is actually provided by the SRTR about how transplant works. And if you look at the blue line and you move from left to right, you can see a patient's considering transplant, seeking a center, being referred, evaluated, listed, and you move through, and then they get a transplant, and we try to support them on it working forever. Okay, that's a lot of good people in this room are on the blue line every single day. But then what you can see is all of these different care supports are happening as well, and you can see the pattern. So what's exciting is where are we losing the blue-lined people? So the key that's great is we said we're going to build 3 points of loss. Where are patients referred for transplant but never beginning evaluation? So that from the outside, they didn't get in for day 1 here. Second part is they began transplant. They started evaluation, but they failed to become waitlisted. So we got them here, you guys started, and they did not finish what was required. And even if they completed waitlisting and they weren't eligible, that counts as a completion. So we're looking for the people who midway through quit. And then the last part is now they're waitlisted, yay. And unfortunately, prior to transplant, due to poor health, death, or other reasons, they are now no longer on the waiting list. So we're moving through. And just to give you a sense of where we are, we don't have risk index 1 because we're actually figuring out how little data we have on risk index 1, right? So someone who doesn't show up, we're really kind of detecting and figuring out, okay, what do we have that can try to do this? But we can definitely talk about 2 and 3 today. And we built our data set. So how this works is at the top you have Houston Methodist's data from Epic, and we have demographics, encounter dates, types, different points of time, a lot of data, which is crucial, a lot of clinical data, a lot of social history data, labs, and then we merge that with the CDC Social Vulnerability Index, say that fast, the Neighborhood Atlas Area Deprivation Index, and the US Census. So all of this data, we're pulling data from geographic matching, so the zip codes of people we're connecting, and so now here's all the data we have in a poll. Epic plus geographic data about where the patient lives. So the important thing from a data standpoint is we have exact data on Amy, and then we have a lot of data on where Amy lives that might be correlated, okay? We put that together and we actually looked at people who've come forward for transplant from 2016 to 2022. And we wanted to look at who never became waitlisted and who failed to obtain a transplant. So I want to show you this because this to me, I could just sit here and look at this for a bit, and I want you guys to look for just a sec. So there's a lot of hard work going on clinically, and I'm inspired every day to work here. And if you look at this data that we pulled for the study, there were 4,245 people who began evaluation. And what you can see is less than half of them were waitlisted in 12 months, and only 13% were transplanted within 12 months. But if you move over to the non-Hispanic, Black, and Hispanics, you can see that we had 13% success at transplants for all of our patients, only 7% for Black patients, and only 12% for Hispanic patients. So we're actually not that off on the Hispanics, but we really have some work to be done on the Black community. So what's going on? So this is what we found, first of all. So looking at risk index 2, we found that 52% of patients who began transplant evaluation failed to become waitlisted within 12 months. That's what we're seeing with the data that we have. And we haven't written this up, so if my smart friends say, hey, let's look at this clinically, happy to keep improving this. The other part is we found, even with the healthy people that got waitlisted successfully, that you think they're almost there, 30% of them were removed from the list due to poor health or died or for other reasons. So there is so much opportunity right now to support even the patients we see. Make sense? Okay, so who are they? That's what I want to know, because I want to see how we can be better in their world, bringing interventions that would really help them. So what we found, so this is the one for dropout prior to waitlisting. So what David Hsu and I and a lot of good people did is we created a risk index profile. So remember, this isn't asking a patient anything. It's just running AI and machine learning and finding and putting people into risk profiles, and we can find what's the difference between the green group and the red group. So the red group are more likely to be Black, Hispanic, unemployed, have a below college education, they don't have living donors, and they've spent more time on dialysis. So the red group of patients have a 27% chance of being listed within 12 months. If you look at the middle risk group, which also to me we could be intervening as, they have a 54% chance of being listed. Now, I want to talk about bias. So the thing that has been fascinating working with the AIM Ahead group is if you look at this data, we could really say, well, let's only transplant the low risk group. They have an 81% chance of success. We can now, ahead of time, say this person's going to make it through. We're going to back them up. We're going to get them through. That's going to make the most number of transplants, the most amount of profit for the transplant center. So this is an example of where we as users of data need to be very responsible, because it also could say, let's not waste our time with the high-risk patients, right? So what I want to say is the big push that I am learning as a researcher in this space is when you get this information, you need to be very, very responsible as a clinician and as a person who, to stand for not using it to make the disparity worse, right? Okay, so I just want to say that as a kind of position here, because you can see these are the people being left behind. And now we can actually know on day one. We can know within day one, first application, walking in the door, first evaluation. Similarly, waitlist removal. We have older patients are being removed from the waiting list, unmarried, interestingly enough, importance of a husband or a wife or a partner. I don't know about how you can make it to transplant. Unemployed, people with below college education, current smokers, higher BMI, and then again, people that are in more socioeconomically challenged environments. Same kind of pattern. Both of these are good risk indices. They're not perfect, so according to the machine learning people, we'd like to add more types of variables to create better discrimination. But already we can find the patients that are most in need of interventions. So going back to this, let's go back to this question that I asked. Where could we apply AI and health IT solutions to improve or deepen the patient experience and make it easier for you guys? When is the compassion and care from a clinician or educator essential and irreplaceable? Or for certain patient groups, we can just see now we have certain patient groups that are not making it through, right? And then how can we build care delivery improvements that incorporate the best of both? So here's where I come in, and this is where the field I'd also want to say has been shifting since I've been doing this for 20 years. Usually when we saw a model like that, what we would say is, okay, all right, let's figure out internally, let's bring all the clinicians together, let's talk about what we think we should do, and then let's build that, right? The patient-facing, the view of research now, view of interventions, is that patients should be at the table at all decision-making points. And this is actually a really good point. And I want to give you two types of patients that could change the game for us. The first part is we should get some high-risk patients from these groups, right? So someone who is like different people, if we could talk to them and say, okay, what would help you the most? Would it help you? Do you need more help at home or in your community? Do you need more help here? Do we need to make the practical realities of this simpler for you? Do you really understand why you want to fight through to transplant or not? Do you need financial assistance support in some arenas? Okay, we can really get that. Often we don't ask them though. We just think we know, right? These are our guesses, and I want to say I pulled all of these from the literature. This is what we do regularly with high-risk patients that are going to drop out of transplant. So where I listen a lot is what is in my blind spot, right? These make sense to you. I bet you could, if I said, how could we do stuff? We as a group could have come up with these. So the question is, where are we not in the world of a high-risk patient where they're not going to make it through? So here's the other part that's really, really exciting. So there are some high-risk patients, 27% to be exact, who have made it through. They're the winners of the transplant lottery, right? What do they know that we could impart to other patients who are not as successful? Maybe it's not about the privileged. Maybe it's about the wisdom of the successful people sharing with the people who were not successful. So the last aim of this grant is to do a series of focus groups and interviews with the patients that either we've lost already from the past, or that patients that are moving through, to see what they need to build interventions, and to bring that back to the clinician team to say, now we have a clinician and a patient-guided intervention. So the other part, though, that I want to say, and you could say it too, is 4,000 patients isn't a lot. That's actually where I started. I thought this was like a small thing. What happened when we presented this is that people said, oh my gosh, you could do something about this. Turns out that a lot of these data sets are not connected to a clinical pathway of any kind. They can learn, they can write a paper, and then they move on. So when I spoke, they said, how did the doctors let you change anything? That was the question. How did the doctors? And I was like, I don't know. I just asked them. Dr. Gaber said I could, right? So part of this is we're in this incredible opportunity that if we can use this data and then we can partner clinically and we can apply some of this data to guide what we're doing, the possibility is that we could make a difference and then provide best practices for places where that they don't have the ability to test this. The other part is there's tons more variables. It is amazing the amount of publicly available data that is out there about all sorts of things. So we've now partnered with like a data warehouse kind of organization for all of these types of disparities type variables, because the biggest challenge is, well, which variable do you want to use and which one matters if there's like an infinite number of databases and all of these different variables. So we are learning how to use disparity related geographic variables to guide health. And then we're working with Harvard now, and we are actually creating a second pilot test of what we're doing here with the Harvard Transplant Center. So the idea is we're not even merging them. We're saying, here's what we did with 4,000 patients. Here's your transplant center. Can you run the same algorithm to see if you're getting the same thing? So now we're making it better. Now, this is when it gets fun. So we got here and we got through the pilot, and they said, okay, you could maybe do something bigger. So what I said was, okay, what do we need? We need more data, and we need smarter people that are patient-facing to take this to a bigger level. So Dr. Gaber and Dr. Figueroa, who runs San Antonio, they are now partnered with us, and Dr. Adjawale, who's at TSU and who's a medication claims specialist. And what we're doing now is building a Texas registry of 50,000 CKD 3B to 5 patients. So not just the 5s, which is what the first data was, but the people closer to transplant to the end. And we're looking at an even broader number of metrics. We're looking at pharmacy fill data, because you could actually be intervening there. If you noticed, a lot of the variables are the particular things that you would say are socioeconomically challenged, and you kind of don't have a lot that you can do. But what if we can see who's not going to fill their meds, right? How could that help? How could we train them? The other part is we're starting to look at questions like rapid progression of CKD. If we can find them out in the community prior to getting to us, and we have a lot of access to that kind of data too, then we can look at failure to complete evaluation and overall mortality. Now we've got the whole pipeline, so we can add another risk index. And then can we build both clinical interventions and community interventions? Because some of our community members need help outside of us. It's not that we're a part of the story of care. So that is what's called a care delivery pathway. Can you kind of get the feel of it as we're talking? Like it's an infinite number of touch points of a patient, but looking at both data and the best of us to make a difference. I also want to introduce a couple things since we're together. So one of the things we have here that we're looking into building a health IT grant is we have CareSense. And CareSense is a patient-facing communication tool that we have here. Has anybody used it? Okay. What I think is interesting about CareSense is you can build scripts, kind of like your script for a movie. Okay, but what the script does is it says, welcome, Amy. you're going to begin your transplant evaluation experience, and then here's some education that might help, and here's some information about how you can get to the garage to park, and here's how, if you need money for parking, you go here. This is a big clinical endeavor. This isn't something I would do alone. It would be all those smart people doing care, but the idea is, can we build, in partnership with the excellent clinical care that's happening, a technology pathway of reminders, of education, of question answers. You can do surveys. You can also include measures of how well they're doing, and if they're having pain, if you're at the end of the experience. But CareSense is very intriguing and is not in a lot of places. Another thing that's really cool from an AI standpoint is that Pieces is a tool that is it's being explored here, where you can scan the social worker notes. So imagine they go through a social work evaluation here. That's where a lot of the potential breakdowns in somebody dropping out might be named, but not ever put into a categorization, right? You can't say Amy has a risk of, doesn't have a car, doesn't, but they're collecting this information. This is an AI tool where we can find this information and we can then get it into trying to provide solutions. So this is an example, again, how technology, AI and technology and care could be connected better. So this is fun. I'm working with Roberta to fill this out. But what I want to leave you with some time to talk is that we need to use creative applications of AI and machine learning. And we need to see if they work or not, see who likes them, see where they break down. Dissemination and implementation research basically says a failure is as valuable as a success, right? So if you guys go and you say, let's try this, and the patients hate it, it doesn't work. There you go, now we know, right? We need to keep testing how this can be incorporated into care. The other piece is there's massively high dropout, and I know you know. I'm speaking to the choir here, and the key is Black, Hispanic, unemployed individuals, and those living in areas with high rates of poverty have an extremely low chance of making it through. And the question is, how can we then know that somebody fits into a higher risk category? Don't make them wrong, but provide resources that could better support them in the process, that are not about adding more work for the clinician, but that are providing a greater foundation for success for the patient. So we are validating indices, we are doing interventions, and the idea is that we're going to build a trial that we can show how more patients can reach transplant successfully, especially those that are in disadvantaged groups. Thank you very much. Any questions or comments?
Thank you very much. This is fantastic. How patients come to transplant? Do this, that, and the other.
Mm-hmm.
People come, they don't have they're badly on medication.
Mm-hmm.
5,000 for transplant. With a lot of
Mm-hmm. Yes.
and then it's a government issue as well.
Mm-hmm.
And
Mm-hmm.
who gives you
Right, right.
the same thing with
Mm-hmm.
but I don't know what
Yeah, I think
Can
you're...
can you repeat the question, because the people online...
People are listening,
yeah.
Sure. Okay, so the question was, we're really seeing that socioeconomic challenges and lack of finances are preventing people from continuing to successful transplant. And can they change their insurance situation? Do they have any money? Is that even modifiable? So here's what I would say based on what the data that we're seeing right now. I was hoping that there would be clear modifiable things. You need to lose weight, you can get a transplant. We can do something about that. So what about the financial challenges? The feeling for me right now is that I always say you want to offer the opportunity to everybody, right? And then we need to see how often that's the deal breaker and know that we've done what we can do. I'm very curious what the high-risk patient interviews will say on this. I'd like them to speak to this, because are they quitting because it's only money, or is it a lot of things? And sometimes for a person who does not have a lot of money, they're facing so many challenges. So I think you're pointing to the thing we all care about. I don't know what the answer will be. More to come is what I would say.
Any other questions? So I have a bit of a, when you present the data, I mean, before you even started putting the registry, you and I predicted this outcome, right? We knew that people that are the socially, economically disadvantaged by demographics are going to be the ones that don't progress and so forth. We knew that. But what we have not done yet, and it struck me as I'm listening to you, is are the high-risk group actually medically also high risk? Is there a medical reason? Because you would assume that people in the high-risk group would medically have more comorbidities, worse healthcare outcomes, right, than the people in the high risk.
Yep,
I'm really leery of the fact that when we present this data, particularly to all the young minds, right, it cements in them the idea that there is some form of discrimination in the process. And having witnessed this process for many, many years, right, we are made responsible for the ills of all of society. I mean, society is working in silos, right? You only get Medicare after this much time, and you get it for this much if you've worked for that much. And if you don't have this, you don't have that. And if you don't get an education, you have to get the education from a different institution. And the Medicaid is by the state government, and the Medicare is by the federal government. And the federal government only pays this much, and that's the maximum. And, you know, it's a very complex web that eventually represents itself in that. And the question is, when you talk about providing resources for these patients, number one, in my mind, is there a medical, are the low-risk people of highest quality health, or is it just socioeconomic? Because it makes a huge difference in the conversation. And number two, when I was, one of the goals that I made for being president of the ASTS was to create a system of financial support of the poorer patients going to transplantation. We have a system for financial support for living donors called NELDAC. And I have lobbied HRSA and CMMI to create a demonstration project to have a system for the recipients, a recipient NELDAC. And I think that would go a long way. So if you look at why somebody doesn't show up, it maybe they don't have gas, they don't have $15 for the parking, they don't have, you know, it's simplistic things, but it's ingrained in society. Should we look at the correlation of these risk categories with something like the Houston Medicine Morbidity Index? That's something Richard and I invented many years ago.
I'd love
to say, okay, 1, 2, 3, if you have heart failure, if you have lung failure, if you have, you know, this, you get 1 point, 2 points, 3 points, 4 points. Now, we also, in our program, exclude people who smoke. And it may be that people at the high risk have much higher incidence of smoking than people at the low risk. So it's multiple, but I'd like to tie it to a medical reason so that we can understand, besides the socioeconomic demographic factors, are there medical reasons or not?
Yes, I love that. So I also had a thought based on what you're saying and what Dr. Gobriel asked. There could be something about the financial components that are extremely true in the high-risk category and somewhat true in the middle risk. So so I would be scientifically really interested to see if we're predicting the low risk against the middle risk. What are the factors? Because that group might be different in the level of impact of the socioeconomic kind of challenges. So what we're all talking about really, it's not even socioeconomically, it's non-modifiable factors, if you think about it, right? So there are things we can intervene with and there are things we can't. But I'd also say that it's not only about us. So going to the community-related interventions, one idea Dr. Gobriel said was, let's go out in the community and make it easier to do different things. Don't make them come in and pay for $15 of parking, just go out to them, right? Like overcome it in a different way. So a lot of this is about, again, going back to doing the same thing, expecting different results is dumb. Not us, but just The field isn't increasing transplant rates. These are the people that we're leaving behind. So for me, as an innovator, I'm thinking, okay, where can we use the new tools? Where can we try something, apply something that people think is a good idea, but it's harder to build because we know what the results are going to be currently. And I want to leave you with that. Like I've been acknowledged for being an innovator, and sometimes people are annoyed because they're like, stop, you're adding stress. But I want to say, keep thinking out of the box. Right, when you see these patients and you see like where are they getting stuck, and ask, where is there anything we could do better? Is there anything else you needed as you go about and interact with them? Great. Thank you so much.